So welcome everyone. In case you don't know me, I'm Amanda Eggen, the Director of Patient Engagement and Clinical Programs with the Runkson Research Program. And I'm here to kick off the webinar about the stem cell harvesting and banking clinical trial at CHOP that Dr. Olson leads. We're delighted to have you here, Dr. Olson. We understand you'll tell us a bit more about the study goals, who's eligible, and what a patient can expect when participating. For those of you who don't know Dr. Olson, he's a physician and researcher at the Children's Hospital of Philadelphia. We call CHOP. He specializes in pediatric hematology and oncology, and his clinical focus is on bone marrow failure syndromes and inherited predispositions to leukemia, like RUNX1-FPD. We have had the privilege of working with Dr. Olson for several years now on many things, and you've really become a trusted advisor to us. So thank you so much for your continued collaboration, flexibility, and your innovative work that you do and your genuine compassion for this community. Okay, so I'm going to shift forward and say this presentation that Dr. Olson has prepared is, specifically for patient audience. We know we've had some scientists and clinicians register, but we'll try to prioritize patient questions first. But we are glad to have everyone here. We know it's important for physicians to also be aware of the study so that you can tell your patients about it as well. So let me just cover a housekeeping item here at the bottom. What should be at the bottom of your screen, it depends on whether you're on a tablet or a computer or a phone, but you should be able to find a Q&A icon. And so during Dr. Olson's presentation, feel free to open that icon up and type in any questions that arise while you're listening. We will return to those questions at the end of his talk to have him answer those questions for you. And please note there's a little checkbox where you can mark answer or ask question anonymously if you'd like. We won't share your names regardless. This is in webinar format, so you can be anonymous. But if you're more comfortable, you're welcome to use that anonymous feature. And I think that's it, other than saying, please feel free to answer, ask any questions that you have, because a lot of this can be pretty complicated. And if you have the question, someone else surely will as well. And I think that's it for me, and I will hide my face. I'll let Dr. Olson take it away, and I'll return at the end for Q&A. Let me stop sharing and let you share your deck.
All right. Thank you, Amanda, for that very kind introduction. And I'm delighted to be talking with all of you today about the study that we have open here, which is a parallel study to the one that's open at MD Anderson in Houston, which is safety and feasibility of doing autologous stem cell collections for patients who have RUNX1 familial platelet disorder. So let me go into a few slides of the background as to why this is becoming increasingly relevant, even in the 3 years or so since we started talking about putting together this study. First of all, here are my disclosures. Nothing is particularly relevant to this presentation. So the reason why this is becoming an increasingly important area to think about is in the field of cellular therapies, stem cell-based gene therapy has really arrived. This is no longer a future pipe dream. This is what we are now doing every day for patients who have certain genetic blood disorders. And it really has a long history of development dating back to the 1980s, when the first genes were discovered to be related to these blood disorders. Soon after that, there were a few shots on goal with gamma retroviruses and a few other approaches to try to make gene therapy safe, and there were some ups and downs there. But today's momentum really started in the last decade or two, first with the advent of lentiviral gene therapy approaches, and then with the idea of gene editing-based gene therapy approaches, which started with basic CRISPR-Cas9 approaches and have since sort of moved on to things like prime editing and base editing as well. So what this means is that if you work in a transplant center, It's probably hit more of the pediatric transplant centers than the adult transplant centers so far, but it's hitting both. In the last 5 years, we realized that there have been 5 FDA-approved stem cell-based gene therapies for blood disorders and metabolic disorders in the US. So beta thalassemia major, sickle cell disease, and then a couple of diseases known as leukodystrophy disorders. There are approved stem cell-based gene therapy products. At my hospital, we are a qualified treatment center for all of the FDA-approved products, and we have already treated over a couple dozen patients with the commercial gene therapy products here. So for patients with RUNX1, the way I would view this is that it is no longer an if, but a matter of when there will end up being a gene therapy strategy available for germline RUNX1 conditions. Now, the problem with gene therapy currently is the cost. These therapies are extraordinarily expensive. The picture of me there infusing a cell product is actually the first cell product, commercial gene therapy product ever to be infused in the United States. This was a few years ago. And I put this up here not to tout our center or to brag in any way, but I put it up because as soon as CHOP sent this picture out on social media, I can't tell you the number of friends of mine that texted me to tell me they could almost see my hand shaking administering the cell product, knowing how expensive the contents were. So the cheapest commercial gene therapy product available right now is $2.3 million. The most expensive is $4.2 million. And this brings up huge questions about costs and sustainability and whether private and public insurance plans will pay for these therapies. There is some rationale for the expense, but the bottom line is the cost of these therapies is really getting in the way of companies wanting to develop new therapies for patients with blood disorders. But there is another advance on the horizon, and that is that cell manufacturing labs, which most academic centers have, are now developing the technologies and the tools to be able to do gene therapy manufacturing on site. So point of care closed system manufacturing is really starting to become a reality. And this means that academic centers can be in charge of making their own gene therapies. And they can be made at a fraction of the cost of what is being charged with industry-based therapies. Academic centers will develop them because of patient needs and not because of financial incentives. And I'll just tell you that just in the past month, we have treated our first patient on one of these homegrown, if you will, gene therapy products and gene therapy manufacturing approaches. And so I really think as we go into the next decade, this is going to provide more and more access to patients with other blood disorders, including perhaps RUNX1. So the way that gene therapy works is first you have to be able to collect stem cells from the patient. And this is different than a traditional transplant where in a traditional transplant, we're collecting the cells from an alternative donor. In the case of gene therapy, we have to first screen and make sure that a patient is eligible for the gene therapy, and then we collect their own stem cells. And once we have successfully manufactured that product and done all of the release testing to make sure that it's a safe product to give, and that's a process in and of itself that takes around 3 months or so, then we're ready to do the transplant phase of this, which can be done typically with just one chemotherapy drug to wipe out the native stem cells and make space for the gene-modified stem cells. And so it causes fewer issues with respect to immune suppression because of that. Now, there are two general approaches to gene therapy, one of which is adding in a healthy copy of a gene, and you can do that through what's called lentiviral transduction. That can be problematic in conditions like RUNX1 FPD because you can't necessarily control the gene dose as well, and you don't necessarily get rid of the dysfunctional copy of the gene. And if that dysfunctional copy of the gene causes problems in and of itself, then you might not fully correct the risk of malignancy down the line. So the approach that more and more centers are looking at for these leukemia predisposition syndromes are a variety of techniques of gene editing, all of which are based on CRISPR-Cas9. And traditionally, they have been used to disrupt regulatory genes to enhance expression of other genes that can ameliorate the phenotype of diseases. But we are now starting to get good enough at these technologies where we can actually directly correct the gene mutation of interest through techniques like base editing as well. All right, so the challenge with applying to gene therapy to diseases that have myeloid malignancy predisposition is you really need to be able to catch the stem cells before they're far down this spectrum of progression from just having a basic germline predisposition to then developing myelodysplastic syndrome and to then developing leukemia. Because once myelodysplastic syndrome has actually already developed, it may be too late for the gene therapy to be able to prevent the ongoing progression of the disease. Sorry, hold on just a second here. I did something funny, and now I can see all of you, and I can't see my slides anymore. So let me see if I can fix that. There we go. That's better. Okay, can you guys still hear me okay?
So we can
Yes.
see your slides and hear you fine.
Perfect, great, thank you. All right, so there are only two different ways that we can prevent myeloid malignancy in patients with RUNX1 FPD. The first one is by doing a preemptive allogeneic transplant. And there is another effort within the RP that is working to sort of codify principles around the concept of when it may be appropriate to consider a preemptive allogeneic transplant. The bottom line is that this requires you to do the transplant if it's going to be preemptive when the marrow is healthy. And this means that you're intervening at a time where you don't know yet if a patient is going to develop myeloid malignancy. There's also the risk that if you do this preemptively and a patient winds up with a severe complication of a traditional transplant like graft versus host disease, patients may wish that they would not have gone to that therapy. You also want to be able to pursue this before clonal disease has come on, because otherwise it might be too late for optimal outcomes. And then the other problem with the traditional transplant is, what if there is no suitable donor available? So if we had a gene therapy available, what would the gene therapy challenges be in RUNX1 FPD? Well, one of those challenges is similarly that you really need to collect the stem cells before they've developed mutations that are irreversible, and then would put that stem cell and its progeny on the path to eventually developing MDS and AML. And the challenge there is that we now know from the work of the RRP and the NIH and others that clonal hematopoiesis, the onset of mutations in the bone marrow, may predate the need for transplant by decades in some patients. And so, one would have to really collect the stem cells ahead of time if you wanted to be able to apply the gene therapy technique to them. We don't know how safe it is to collect stem cells in patients with RUNX1 FPD. We have a high suspicion that it is going to be very safe since we have experience in patients with other blood disorders, but that's going to have to be proven before this technique of gene therapy for RUNX1 FPD can become a reality. And then the final thing is we need stem cells from patients with RUNX1 mutations for research where we can actually develop these successful gene editing techniques. And so this was a long-winded way of getting me to the point of this, which is all of those concerns about gene therapy are why we have gone to develop along in collaboration with Katrina and Amanda and the RRP, this stem cell collection protocol for patients with RUNX1 familial platelet disorders. This is the team. This is our team here. This is being led by a junior investigator here, Nora Gibson, and it is an identical protocol to the protocol that's being run out of Houston by Chitra Helsing and Courtney DiNardo. So the objectives and endpoints of this is to evaluate the primary objective is to evaluate the safety of harvesting stem cells in patients with RUNX1 FPD and make sure that this is as safe as we expect it to be for patients. And then the secondary objective is to evaluate the feasibility of collecting enough stem cells from patients that we can bank aliquots of stem cells such that in the future, if gene therapy is developed, we can use those bank stem cells to apply that gene therapy technique to. So we first want to be able to collect enough stem cells that we can have a backup of a patient's own stem cells at a time, hopefully before they have developed significant clonal mutations, so that we would have a backup on hand if we can go on to develop a gene therapy in the future. And then also we could use this as what we would call an autologous reset, which is if a patient needs a transplant, 10 plus years down the line because they've developed MDS and AML, and if there doesn't happen to be an available donor and maybe gene therapy hasn't developed yet, we would have a healthy banked dose of cells in the freezer that we could use to perform what we would call an autologous reset in that scenario. So we also then want to see how many participants who we put through this collection protocol, can we collect enough stem cells? And typically that's thought of as collecting at least 15 million stem cells per kilogram of body weight, that if there is the technology in the future to develop a gene therapy for this, we would have enough cells to be able to apply to that technology. So our goal is to enroll 6 patients on this study. Our IRB has dictated that we are limited to patients 18 years and above, at least for the first few patients. And the IRB considerations there have to do with we first need to establish that this is safe in adults before we can move this into pediatric patients. The study has 3 phases. So the first one is screening. The second one is the mobilization and the apheresis. And then the third is the follow-up phase. And I'll just point out that that follow-up phase, which is up to 2 years, nearly all of that follow-up phase hopefully can be done at your home center if you are thinking about traveling to Philadelphia or to Houston to participate in this study. So to be eligible, we are going to have patients go through this set of screening studies, and it includes basic lab tests like CBCs and liver function tests and basic chemistries and coagulation parameters, basic infectious disease screening as well. We do have to have a confirmed RUNX1 mutation that is consistent with RUNX1 FPD. And we will require bone marrow screening and a myeloid mutational screening panel to make sure prior to doing the stem cell collection that there is not already a high-risk genetic mutation in the bone marrow and blood of a prospective participant in the study. So the screening phase is expected to last about 90 days or so. We do all of the assessments that are listed in that blue table to the left. This includes hopefully timing correctly with a patient's routine clinical bone marrow monitoring for a given year. And we are going to use that bone marrow monitoring to do those genetic assessments that we mentioned as well. To be eligible, patients have to be at least 18 years of age, which I already mentioned. They have to have a confirmed diagnosis of RUNX1 FPD. Our apheresis team has to clear you for stem cell collection. A big part of that is to make sure that you don't have severe hypertension as listed here. And then if your platelet count happens to be lower than 50 at baseline, you would have to agree to platelet administration on the day of collection to ensure that it is safe to do the collection without concerns for bleeding risks. Exclusion criteria, I already mentioned the presence of clonal hematopoiesis could be exclusionary. We'll talk about that more on the next slide. If you already have a diagnosis of MDS or recent other cancers, this will likely be an exclusion criteria. Now, the exceptions are if you had a precancerous or even a cancerous skin lesion removed more than 5 years ago, we would not, and you didn't require systemic treatment for that, for example, we would not exclude you from the study for that purpose. You can't have evidence of immune deficiency, and your liver, your heart, and your lungs all have to be functioning well. And certain infectious diseases, if you screen positive for them, might be exclusionary as well. If you're pregnant, we don't think it is worth any theoretical risk to undergo the mobilization and the apheresis, so you would be temporarily excluded. And then psychologically, we just have to make sure that any participant fully understands the consent and is able to complete study procedures. So which clones might be considered an exclusion for this? The bottom line is this is up to our discretion. This is how the protocol is written. And I will just give you a couple of examples based on this wonderful work from the RRP and from Paul Liu's group, which shows that clonal mutations in patients with RRP are very common across the board, and some of them are more worrisome than others. For example, patients can have clones defined by B-core mutations that can be dormant for long periods of time and are not necessarily associated with malignancy. And so we would factor into our decision-making sort of what we know about the gene that is mutated and whether or not we are worried that this could indicate high risk of progression to MDS or AML. Certainly any second hit RUNX1 mutation or a cytogenetic change, meaning a whole chromosome change, like a loss of chromosome 7, which is also called monosomy 7. If you had one of those two things, that would be exclusionary from enrolling in this study. So this is what the follow-ups look like and what the participation looks like. So you would, if we complete the screening and you pass the screening, we would have you come in to start 4 days, or actually 5 total days of injections of a medicine called GCSF, which is an injection under the skin, and it serves to push stem cells out of the bone marrow and into the circulation. And so you would have a clinic visit for day 1 of that administration. We would teach you how to administer that, and the next couple of days you would administer it from home. And then on the 4th day, depending upon how good your veins are and your willingness to consider placement of a central venous catheter, we may place a central venous catheter to help us aid in the apheresis collection of the stem cells. If you do get the catheter placed, it means that you will likely be admitted at least overnight into the hospital and for a maximum of 2-ish days. And that is just to make sure that that line stays in place and you don't have any problems with it. I will say that while the central line placement is not mandatory, what we've learned from doing gene therapy stem cell collections and other conditions is having a central line as opposed to regular IVs greatly increases the success of our stem cell collections. So on the 5th day of the mobilization, we would give you 1 last dose of GCSF. Based on testing that we are doing, if we think that we need to push more stem cells out to get a good collection, we may give you a dose of a second medicine called plerixafor as well. And then we do the apheresis procedure. And hopefully we collect enough cells in that single day of apheresis that as soon as we're done with the apheresis, we can take the line out and we can get you out of the hospital. The protocol is written so that if you are amenable and we think it would be beneficial in terms of collecting more stem cells, we can do a second day of collection as well, but that would be a joint decision between you and our clinical team. Once we're done with the collection, once we've removed the line, we would have a follow-up visit within 1 to 2 weeks after apheresis, just to make sure you're doing okay and make sure that all blood counts are looking good. We would do this one more time, 3 to 6 weeks after apheresis as well. And then we would have follow-ups at month 6, at month 12, and at month 24 after apheresis. There is only one of these assessments that is required to be done at CHOP, and that is the 6-month assessment, because we very much want to repeat a bone marrow aspirate and biopsy at 6 months. And the reason why this is so critical is we want to make sure that by putting you through the process of stem cell collection, we don't see additional new mutations developing in the bone marrow. We think that there is a very low risk of that, but we also know we're going to have to prove that if we wanted to move this into common clinical practice to bank stem cells for patients with RUNX1 FPD. Now, there are a few risks of going through this process. I am not going to go through all of the risks that we would talk about on a consent form, but I'm going to hit a few highlights here. So the most common side effects of going through the apheresis collection are a little bit of lightheadedness, some flushing, a little bit of GI disturbance, a little bit of nausea. It can lower platelets a little bit, and because it can affect electrolytes temporarily, some patients will occasionally report muscle cramps. We expect all of these side effects to go away within 1 to 2 days. The medicines that we use to push the stem cells out of the bone marrow and into the blood can cause a little bit of bone and muscle pain, and there's some medications that we can do to give you to alleviate that pain. And then rarely we can see some allergic reactions. And then in patients who have very big spleens, which, by the way, that's a contraindication to enrollment here, sometimes one can see some spleen complications from these medicines. And then risks of the main risks associated with putting in a central line is that it can be a little bit uncomfortable while it's in place. You can have a little pain at the site. And we generally place the line under anesthesia, and that comes with all of the risks that go along with getting anesthesia. So what are we trying to get out of this study? Well, the key safety analyses are going to include the proportion of patients who are able to make it through the mobilization and who are able to make it through the apheresis. And we want to record all of the side effects that anybody who is going through this therapy develops. We also want to make sure, as I mentioned, that we don't increase the number of clones in the bone marrow by putting patients through the apheresis collection. And so we'll be monitoring laboratory values fairly closely as well. And then finally, I just want to land on what are we going to do with the collected stem cells, right? Well, it's going to depend on the number of cells that we collect. If we're only able to collect a small number of cells, we're going to prioritize saving a small bag of cells to be able to use for that autologous reset or backup purposes. You'll have cells banked that you could use in a severe clinical scenario in the future if you needed it. Any leftover cells from that would be able to go for research to try to develop a gene therapy. If we collect more cells, at least 5 million per kilogram of your body weight, going all the way up to 25 million per kilogram of your body weight, that's when we're going to be able to bank cells that can stay in our freezer and could potentially be used to manufacture a gene therapy product in the future once one has been developed and validated for patients with RUNX1 FPD. And then in the event that a study participant cells will no longer be used, meaning that we don't need to hold on to them for the future development of a clinical product, it's written in the protocol that those cells may be de-identified and released to researchers who are working on RUNX1 FPD. With that, I just want to highlight the folks in our cell therapy and transplant group here and our collaborators that are critical to this study, including Michelle Lambert, who is a world-renowned expert in RUNX1 FPD, as well as other platelet disorders, Dave Friedman, who is our apheresis director, Nora Gibson, who's going to be leading the study, and then our stem cell lab led by Youngping Wang, who will be storing the cells for us. And with that, I'm happy to take any questions from the group.
Thank you so much, Dr. Olson. Ooh, oh boy, it looks like I froze for a second. Hopefully that wasn't too bad. Um, Great presentation. Thank you. I feel like I learned, I've seen this study presented several times and I learned something new every time. And your talk is always very clear. I just want to remind everyone on the call, if you have questions, feel free to type them into the Q&A icon. I have some questions that I brought from people who were unable to attend live. And so I will start with those. So I want you talked about the schedule, the timeline, and you mentioned that you will. So when patients are there going through the process, you mentioned teaching them the process of administering GCSF. Did I say that right? At home, which sounds amazingly convenient, especially for those who are local. So they come in at the beginning and then they can stay home for a handful of days until they need to come back in, right, for the next step.
Right. Practically, the way that this is going to work out the best is just in terms of days of the week. Having done this for many patients getting gene therapy, is typically day one, the first day of injections, is going to be either on a Thursday or more likely a Friday. And so in our clinic, we will take you through the process of administering the GCSF, which is just an easy injection under the skin. There's nothing more to it than that. It's very, very, very simple. But we'll show you how to do it. We'll make sure you have the supply of the medication. And then day 2 and day 3 are typically a Saturday and a Sunday. And so you're on your own to do those injections. We obviously have people on call to take phone calls if there are any questions or anything arises during those 2 days. And then day 4 tends to be a Monday. And that would be the day that if we're putting in a central venous catheter, we'll put that in that day. And so you can either self-administer that dose of GCSF in the morning before you come in, or we can take care of it once you get in. Either of those things is fine. But that's typically what we do on day 4. And then day 5, if you do have the central venous line, you would stay in the hospital overnight so that we can get started first thing that next morning with the apheresis collection at 7 in the morning or so. So that is what that looks like. Now, if you are deemed a candidate to try this without a central venous line, then this would be outpatient, and you would show up that Tuesday morning to the apheresis clinic, and that's where everything would get started. And that would mean that you would need to self-administer the GCSF on day 4 and day 5, if that's the case.
Okay.
So hopefully that wasn't too long-winded of an answer, but that's how it logistically looks.
Yeah, that's helpful, and it sounds pretty simple. And it's encouraging to hear that patients can do this at home. And frankly, there are medications that a lot of patients are administering to themselves. It sounds similarly at home these days, so it sounds pretty simple. And I wanted to mention, but with our community being all over the place, and we've and for those who might not already know this, we at RRP are glad to support travel and hotel lodging, etc. If you would like to travel to Philadelphia to participate. So for those guys, how do you imagine that working for them? Would you do the same thing? Would you have, we would put them up in a hotel, it sounds like, for at least the 5 days, and they would administer, or what's your vision for that situation?
I think that's exactly right. I think we can do this with local housing, temporary for that week. I think the decision making, if you were traveling into Philly for this, is less about that week, because I think that's very straightforward. We would work with you to be in a local hotel, and we would get you all the things that you would need. I think the bigger question, if you're traveling in, is how long you would then want to stay after the collection, because we do have that follow-up visit that is supposed to be about a week or so after the apheresis. And in talking to Katrine about this and to others, we wanted to make this as flexible as possible in terms of what needs to be done here versus somewhere else if you're traveling. And so we're amenable to make it work in different ways. But I think that would be the bigger question to ask somebody who was traveling in, is whether or not they would want to go ahead and stay here for that next follow-up a week later, or if we would need to get that set up with your local physician. So.
Okay, that makes sense. Yeah, thank you for that. That was kind of what I was, that was my next question about that.
Right.
Okay, that sounds good. And then I think related, let me see if I had another question there. Yeah, I think that covers it. So, and then also with those guys that are in the hotel, you would probably have them come in each day for administration, or again, they could just administer themselves, right? And sort of treat it like a holiday, I
Yeah,
guess.
because
Yeah.
it's going to fall over the weekend, we would rather them, if they feel comfortable, we would much rather them self-administer the GCSF on the Saturday and the Sunday for sure.
Yeah.
And then,
Yeah.
the same things would apply on day 4 and day 5, which would usually be a Monday and Tuesday, which is if you're getting a central line placed, you're going to be coming in anyway, and we can help take care of it. If you're not having a central line placed, then we would need you at the hotel to self-administer the GCSF on day 4 and day 5 as well.
Sure. Okay. So pretty simple if they're comfortable hanging out in a hotel and working or relaxing in between visits. And then the process of apheresis, is that just so if they have a central line, they'll have stayed overnight. I don't mean to belabor this, but these are questions I know. They will, if with the central line, they will have stayed overnight and stick around. But should they, even if they don't, like how long would they be on site for that process? What do you expect?
So the apheresis can vary in time depending upon how the collection is going. I would say, what apheresis is, and I didn't get too far into this, is if you do this by regular IVs, it's kind of the easiest thing to visualize. You'd have an IV in your left arm and an IV in your right arm. And the one in your left arm is used to draw blood out to go around in a circuit. And then your own blood is returned back to you in your right arm in the other IV. And a central catheter essentially works the same way because it has 2 lumens. But in between, the blood gets processed through this filtration system that fishes out the stem cells. And so the circuit has to run for a long period of time so that you circulate most of your blood through the circuit, and that way we can maximize the collection of stem cells that have made it out into the blood. This is the same without the mobilization, without the medicine that goes, that gets injected for the 5 days. This is the same process that is used for people who donate platelets for transfusions. So this is what they donate through apheresis as well. So the length of time that you are hooked up to the apheresis circuit or the apheresis machine is dependent upon how much volume of blood we want to process, which is in turn related to how well we mobilize stem cells into the blood. If we mobilized a lot in, then you may only need to be hooked up for a couple of hours. I would say the standard is about 4 hours where you're hooked up to the apheresis circuit. And I think for this purpose, we probably wouldn't go beyond 4 hours. If we wanted to do more collection, we would probably just do it on a second day rather than go beyond that length of time for this.
Yeah. Okay, that makes sense. And you mentioned one of the things I was thinking about is related to that. What you just mentioned, this is a procedure that's done in different scenarios, and I did have the question of sort of, we're testing this for RUNX1 patients to look at safety, but how often do you even have an estimate of like how many patients go through this at a day at CHOP or a month at CHOP? It's pretty common, yeah. It's pretty regular.
Yeah, with the volume of gene therapy that we're doing for sickle cell disease and thalassemia now, plus the collections that we do for patients who have cancer And there are certain types of cancers where you do an autologous transplant for them. There are certain type of lymphomas, brain tumors, things like that. But amongst all of those indications, we're probably doing 2 of these collections on 2 unique patients every week. So this is very commonplace for us. We've done, for gene therapy candidates alone, we've probably done 100 or so of these procedures. And then if you include, the decades that we've been doing autologous transplants for cancer indications, it's really hundreds of patients that have been through these collections. So it's very routine for us. You never say never with side effects, but I would say that it is overall a very safe procedure.
Okay, good. Yeah. Actually, I know this isn't at your location, but we did have Dr. Hosing present at our patient meeting recently, and she was able to speak to at least the first couple of patients who have participated, and they really have only had a handful of those common side effects and just managed it with over-the-counter medication. So that was really encouraging, and it's good to hear that you guys do this all the time as well. And so I know you have to mention those serious adverse events, but it sounds like to me, let me not put words in your mouth. I guess, are you able to say, sort of speak to the chances of these serious adverse events given your experience to date with this process?
Yeah, my expectation is that people will not develop serious adverse events going through this. What I do expect people to feel is by the time you get to the 4th or the 5th day of the mobilization, you'll have a little bit of bone and muscle pain. And that's actually a sign that those medicines are doing what they're supposed to do and pushing the cells out into the periphery where we can collect them better. Ironically, one of the best medicines to deal with that bone and muscle pain is Zyrtec or cetirizine. And so, we are going to advise you of that. And if you start having that pain, to start taking that medicine, and that really tends to work wonders for patients. So that I expect. I also expect for 12 to 24 hours after the apheresis procedure, you're going to be a little bit lightheaded. You might have a little bit of nausea, and you might not just quite feel entirely yourself just because of the flushing and that sort of thing that can happen with us moving all of that blood around. But those symptoms resolve incredibly quickly as well. So it's really typical, the typical experience is that lightheadedness may stick around for 12 to 24 hours and then it goes back to normal. So those are the things that I expect people may experience.
Yeah. Okay, great. That's helpful. Okay, let's see. So thank you for speaking to the remote options. And just so I understand correctly, you do want them to do the baseline bone marrow and then the 6-month bone, or the before 90 days prior, within 90 days bone marrow there, and then the 6-month. Is that true?
I would have to double check this, but I am about 95% certain that the baseline bone marrow does not necessarily have to be done by us. It can be done by your local provider. And the idea is that we can time this. So if you're getting annual bone marrow screenings, which I do think is a recommendation for patients with RUNX1 FPD, we can utilize that annual screening as long as it's within that 90-day window. And if they have sent off the correct genetic testing that I know the RP wants folks to do, that we can use as the eligibility requirements for screening for those clonal mutations.
Yeah.
The
Okay,
6-month
perfect.
marrow, the reason why the 6-month marrow has to be done locally is because that is a marrow that is not necessarily required for routine clinical care, right? We do yearly marrows. We don't do every 6-month marrows unless there's a concern. But we thought that on this study, it was important to look a little bit earlier just to make sure that going through the process of apheresis didn't stir anything up and allow new mutations to be detected. And so that's a specific safety assessment that we put into this study to do a marrow a bit earlier after somebody's been gone through the collection.
Yeah, that makes sense. Appreciated. And I'll mention also that RRP recognizes that maybe, the 6-month marrow outside of routine, if it's cost, if there are cost concerns for patients, given, the role of insurance in this trial, please speak to us because we also have opportunities to support on that side of things. Okay, I have another 1 to 2 questions, if you'll hang with me. Someone had asked about this before, and I don't think we have gotten an answer from you. But you sort of went through the history of gene editing, gene therapies, and how far we've come. I loved your picture, by the way, of the first. Thanks for sharing that. And so we're seeing lots of advancement very quickly in technology. And so one of the things that has arisen is, though, a little concern about those who have deletions, and the concern that, well, those can't be corrected right now. So is this really a trial for me? What would you say to someone who has to see that?
I would say, first of all, that concern is a valid concern, right? I think based on the technologies that we have available today, I think it's much more complicated to gene edit a deletion. I think if one were to develop a gene addition strategy and find that it was successful, that can still be applied to patients who have deletions. In one of the disorders where gene therapy is currently approved, beta thalassemia, oftentimes the genetic defect is a large mutation in the beta globin gene, or a large deletion in the beta globin gene. And so gene addition works for that. And the other thing that I would say is sometimes it's a little bit unclear exactly how specific RUNX1 mutations lead to the development of disease. But in the case of a large deletion, I think we feel like we know, and that is that you're missing a RUNX1 signal. And so in patients that have that genetic defect, gene addition makes a bit more sense than in patients who might have a missense mutation, and you're not exactly sure how that missense mutation is causing challenges with the disease. So the bottom line is, it's a valid concern, but the pace at which genetic technologies are evolving, and the idea that we might actually have personalized base editing for patients with unique mutations in the next 5 to 10 years makes me feel that anything is really possible. If you look in the span of a 15 to 20-year period. And so just because you have a deletion, I wouldn't say that there is no potential benefit in you participating in the study. The other piece of this is that if you have a large deletion and you have already undergone HLA typing and perhaps you don't have very good available donors, then the other part of this protocol that might be helpful is to collect some stem cells prior to the onset of clonal mutations. If you ever needed them in the future, those would be available, even if a personalized gene therapy doesn't come to fruition for you.
Right. And that's the sort of reset that you called a reset. Yeah.
Right.
Perfect.
Yep.
Yeah. Thanks. Okay, great. Well, this final question I have is a little bit off, but it's kind of related to what you just said. But I'll ask it because we've gotten this question a couple times. And I think you and I have talked about this, but there are some patients who are thinking about cord blood. And I know this is not your protocol. You're not collecting cord blood for this specific protocol, but given your expertise in this world, there are some patients who are thinking about, okay, where does cord blood come into play in terms of thinking about therapy for my children in the future, or myself, and also, those who have cord blood stored now, they're wondering, do we do everything we can to save that and transfer it to research centers somewhere where we can use that in the future? Again, kind of forward thinking about, because I think what we talked about before is that right now with technology, that's not enough cells, I believe, or I'll let you speak to that, but I'm wondering also in the future, right? Is this guy, knowing that things advance so quickly, could that be useful 10, 15 years down the road for someone in the clinical setting for treatment?
That is a great question and also a very complex question to answer.
You got
So,
7 minutes. Just kidding.
the basic facts of cord blood versus the types of or the volume of cells that we're interested in collecting on this protocol. If you recall the slide I put up there, we really think that 15 million stem cells, or CD34 positive cells, which is what we call stem cells, 15 million per kilogram of your body weight is probably going to be what we need to manufacture a gene therapy product in the future, right? A good cord blood unit will have 300,000 stem cells per kilogram of your body weight, and that's a good one. Oftentimes, you need 2 different cord units to get up to that level. So we're talking about 1 to 2 orders of magnitude difference in the number of stem cells natively in cord blood versus participating in this stem cell collection. And so I guess the thing that I would say up front, which is not your question, but I would be remiss if I didn't say it, is I would not have the mindset that I wouldn't participate in this study because I have a cord blood banked, because they're not similar in terms of volumes of cells. Now, that being said, there are techniques. There's actually a company called GamedaCell, which has a product that is essentially cord blood expanded with a nicotinamide receptor stimulation to generate orders of magnitude more CD34 positive cells out of a single cord blood unit. And that is actually FDA approved to use in traditional transplants for patients who have hematologic malignancies, so patients who have leukemia or MDS. There are other people that are working on similar strategies of cord blood expansion. And so in the future, could it be possible to use those expanded cord blood units to manufacture a gene therapy product? I could envision a world where that is so. And particularly if, say you screen for this study and we find that you already have a high-risk clonal mutation and we think this isn't a good idea for you, but if you already have cord blood stored, that cord blood might be the only path in the future. So I would personally hesitate to throw it away if it's already stored. And then if you're a parent or if you're a prospective parent and your family is affected by RUNX1 FPD, I would always give the recommendation to bank the impending child's cord blood because oftentimes you don't know whether or not they have the mutation. And if they don't have the mutation, that cord blood could be used as an allo donor product in the future. And then even if they have the mutation, holding on to that because maybe down the line it might be useful, I think would be reasonable.
Yeah. Okay, great. I asked you to have a crystal ball as part of that and answer a big question. Thank you. I appreciate all the parts of that you provided, especially including thinking about it's not a this versus that in terms of this study for sure. Okay. Well, I think that covers all the questions that we've gotten here and outside. So thank you, Dr. Olson. Really, really great presentation, great discussion. And we'll keep, telling people about I hope those who watch this or joined can also tell family members, and we'll get the word out and send patients your way. Thank you for all you do.
Thank you for all that you do. Appreciate the kind words, and looking forward to being able to update everybody on the progress of this study in the months and years to come.